Dr. Kalla has been a staff emergency department physician at St. Paul's and Mount St. Joseph's Hospital since 1998. He is a department head for emergency medicine at St. Paul's and a clinical associate professor at the University of British Columbia. He has 9 novels published that have been translated into 12 different languages. 2 have been optioned for film, and his latest historical trilogy set in World War II, Shanghai, is being developed for a TV series. Here's Dr. Kalla.
Thanks, Natalina, and thanks everyone for joining us tonight. This is something I think you're about to hear that we're very excited and passionate about what we're going to discuss tonight. As Natalina mentioned, I am the department head of St. Paul's, but I also am the least distinguished member of this panel that you're about to hear from tonight. But I really am incredibly proud of my long-term association with St. Paul's. There's such a wonderful sense of family and community that really distinguishes our hospital and our emergency department, I think, from any other hospital that I know of in this city. You know, being the downtown hospital, we also have a fairly colorful spectrum of patients that distinguish us as well. And I thought I'd start with a uniquely St. Paul's story, because you're going to be hearing some sad stories, some heroic stories, but this is kind of a funny story, I think, I hope. But I once saw, it's about 10 years ago, I saw a 35-year-old patient who presented here to St. Paul's Emergency with a heroin overdose. And there's a lot of talk about heroin and fentanyl overdoses in the news. You know, it's a bit of a healthcare crisis, and it's not something to be made light of. But this fellow is kind of interesting, because I don't know if people know, but when you die of or overdose of heroin, what kills you is you stop breathing. You basically suffocate or asphyxiate because the centers in your brain that get you to breathe subconsciously just shut off. So people go to sleep, they stop breathing, and that's how they pass away. But we have this antidote, so if they're found, it can be reversed immediately. It's a medicine that paramedics carry, and we now give it to some patients to take home, called Narcan, and it's this incredible reversal agent. And so I saw this young 35-year-old, quite intelligent gentleman who's hardworking, but he was presenting to St. Paul's the 3rd time that year for a heroin overdose. And his friend had found him blue and started mouth-to-mouth resuscitation and called the paramedics, and they gave him Narcan, and he woke right up. And so by the time I came to see him, he was actually fine. And he looks at me and he says, "Doc, you know, I don't take very good care of myself." And I said, "You know, clinically I would have to agree with you there." And he says, "You know, I smoke, I drink, I do way too many drugs." And he said, and I'm worried about myself. And I said, "And so you should be." He goes, "Doc, while I'm here, do you think you could just check my cholesterol?" And so we did, and we got him on cholesterol-lowering agents, and but I just thought, some people's insight is interesting in our job. So I want to share with you another story that's not particularly unique to St. Paul's. Anyone who's worked long enough in the emergency department has seen a story like this, often several. My colleagues here will attest to that, I'm sure. But one evening about 4 or 5 years ago, I received a call from the paramedics that they were going to bring in a 44-year-old gentleman who was in full cardiac arrest. This was a 44-year-old previously healthy athlete who had no history of illness, had no history of drug use, and he was playing soccer with his son, and he collapsed in cardiac arrest. His wife, who was a nurse, started CPR on him right away, and the paramedics got to him for 5 or 10 minutes. They did everything they could in the field. They worked on him for 35 minutes, but they couldn't restart his heart. Because he was so young, normally they would have stopped there, but they brought him to St. Paul's. We worked on him for another 50 minutes in our emergency department. We threw everything we thought we had at him, and it was to no avail. We had to call it after 50 minutes. And so this 44-year-old healthy father of 2, previously healthy father of 2, basically died in front of my eyes, and I had to tell the wife, I had to break the news. And it was one of the sadder moments of my career. And you know, in the emergency department, we deal with people at the end of their lives all the time. Many of them have battled chronic and complicated disease, and these are often people who've come to a natural end. But I think nothing is as tragic or frustrating to us as seeing a young, otherwise healthy person who doesn't even know they suffer from heart disease drop dead, and then there's nothing for us to do about that, or there wasn't before. And oftentimes it boils down to just a single blocked coronary artery or a big blood clot that has broken off from the veins in the legs and gone to the lungs. And as you're about to hear tonight, that Dr. Finkler and Dr. Grunau will attest to, the statistics for survival, if you drop dead of a cardiac arrest outside of hospital, are abysmally low, no matter how young you are, no matter how good the CPR and the immediate care you have. And moreover, until recently, they haven't changed much in the last 50 years. But thanks to these gentlemen here, and a few other people like them across the globe, we have a new protocol that has the potential to be life-saving to this particular group of patients, those with arguably the most quality years of life left to be saved. And none of the individual technologies you're about to see or hear tonight are particularly new, but the way they've been assembled into a single system-wide protocol, it's potentially groundbreaking. And it's incredibly exciting to even be peripherally involved in the ECPR program that we're pioneering here at St. Paul's. It's the first such formalized program in all of Canada. And with the Foundation's support and all of your support, we hope we can make it something incredibly special and productive here. So I'm very proud to introduce the speakers tonight. Fortunately, we still don't have our cardiac surgeons. We're not sure if they're going to be here or not. But I'd like to start with the man. Well, he's more of a boy, really, isn't he? Who had the vision and the determination to make all of this possible, with the colleague beside him, actually. But Dr. Brian Grunau is the clinical assistant professor at UBC. He's a scientist with CHAOS, the Center for Health Evaluation and Outcome Sciences. He's worked as a staff emergency physician at St. Paul's for over 5 years, and he's just completing his Master's of Health at the end of this month through UBC. His primary research interest is the management of out-of-hospital cardiac arrests in refractory patients. He's been a representative for the Heart and Stroke Foundation on the American Heart Association Heart Saver CPR course program. And as I said, he's now become the point person for the ECPR program at St. Paul's. So, Dr. Grunau.
Thanks so much for that introduction, Dan. And thanks to everyone for coming here today. It's an absolute pleasure to talk to you all about our program that we've developed that we're extremely excited about. So as Dan mentioned, my name is Brian Grunau. I'm a cardiac arrest researcher and emergency physician at St. Paul's Hospital. Thanks so much to the Foundation for organizing this event in which we're talking about ECPR, which is a cutting-edge resuscitation tool for out-of-hospital cardiac arrest that I'll discuss a bit more as we go along here. So sudden cardiac arrest in our communities is a common occurrence. One happens in Canada every 13 minutes. So important first steps are early initiation of high-quality CPR, public access defibrillators, and activation of the 911 service, as you all know. Our local paramedics here in BC are extremely skilled and proficient at performing resuscitations on scene. They have high-quality CPR, they defibrillate the patients, they have advanced cardiac medications, and we have some of the best outcomes in Canada for patients with out-of-hospital cardiac arrest. As you can see here, paramedics typically use these tools on the scene of a cardiac arrest, working hard to bring the patient back to have a pulse for a chance of survival. If they're unsuccessful, however, as Dr. Kalla mentioned, they're typically declared dead on scene, as there's not a whole lot of treatments that we have to offer in hospital that an advanced care paramedic isn't able to provide in the scene. So transport to hospital of people who aren't able to be revived is uncommon in our system here. So as Dr. Kalla mentioned, unfortunately, despite the best available treatments that we have currently with the CPR and the medications, the outcomes of out-of-hospital cardiac arrest are still dismal. Survival is only about 12%, and I mentioned that's higher than a lot of the other centers in North America. So 9 out of 10 people who have out-of-hospital cardiac arrest unfortunately don't survive. And at St. Paul's Hospital, we're hoping to significantly improve that unfortunate statistic. So over the last 10 years, we've been studying cardiac arrest at St. Paul's Hospital and throughout BC, but paying particular attention to the Vancouver area. We have approximately 400 out-of-hospital cardiac arrests in the greater Vancouver region alone, and you can see the density plot of where most of those cardiac arrests happen. Surprisingly, about a third of these patients are quite young, under the age of 60, which gives you some sort of idea of the high rate of premature death in our communities. So this is Sean Murphy, who's one of these examples, a seemingly healthy 34-year-old carpenter with a young son. One evening, while spending time with friends and family, he suddenly dropped to the floor unresponsive. CPR was initiated and paramedics arrived. However, despite prolonged efforts to revive him, they were unable to be successful. His autopsy revealed a genetic heart abnormality. Unfortunately, if you knew about it, it could have been prevented. So it was really unfortunate that we didn't have more treatments to offer this young man with so much potential in his life still. The one fortunate part of the story is that his son was found to have the same genetic abnormality, so he was able to undergo treatment and he won't have the same fate. But it was unfortunate that we did not have more to offer him. Gerald Peters was another cardiac arrest victim, a healthy 62-year-old retired teacher who spent 30 years as an educator. He had just recently retired a year previously and was hoping to live out his days when he had a sudden unexpected cardiac arrest. It was found later to be a heart attack. However, the paramedics were unable to revive him. And again, it was unfortunate that we did not have more to offer this man. So at St. Paul's Hospital, we've identified the number of people in our community with sudden unexpected cardiac arrest, and we think that there's more that we can offer these patients. We've found that a large number of these patients are young, otherwise healthy patients with sudden unexpected cardiac arrest that we just didn't know were unhealthy beforehand. We think that there are further management strategies of the more aggressive nature that should and could be implemented to improve the survival of these patients. The Heart Center at St. Paul's Hospital has extensive experience with providing advanced cardiac procedures, and one of these is ECPR, as you've heard about already. This therapy is really able to give patients a second chance at survival. This is the emergent initiation of cardiopulmonary bypass in a patient who has cardiac arrest, who is unable to be revived. The heart machine is called an ECMO machine, stands for extracorporeal membrane oxygenation, but it doesn't really matter what it's called. It's similar to what's used in heart surgery, and it's basically an external heart and an external lung in which you can, here's the external lung, and here's the external heart, and you can attach this to the patient external to them, and it can provide the functions of the lung and the heart. And this can give the organs the blood flow and oxygen that they're not able to get when a patient's in cardiac arrest. So this is a very complicated therapy to initiate in a time frame. It must be started in a very short time frame after the cardiac arrest if one is potentially going to have a good outcome. Thus, any application of such a therapy must be highly organized and highly efficient. With the interdisciplinary committee at St. Paul's Hospital, about 2 years ago, we began discussing the possibility of creating a regional program to offer ECPR for cardiac arrest victims in our community here in Vancouver. After extensive planning and protocol development, we've officially started this protocol on January 1st of this year. As Dan mentioned, this is the first protocol of its kind in Canada, and it's for patients who have out-of-hospital cardiac arrest who the paramedics are unable to be revived, effectively giving them a second chance in the patients they would have otherwise declared dead on the scene. So our goal is to increase the number of survivors within Vancouver who have cardiac arrest. So who are ideal candidates for this therapy, you might be wondering. So it helps to understand that when someone has a cardiac arrest, the blood flow stops flowing to the organs of the body. The organs don't get enough oxygen, and if the oxygen and blood are cut off for too long, the organs die. So the most important of these organs is obviously the brain, which we hope to keep with blood flow and oxygen when someone has a cardiac arrest. So ECPR, we're really re-establishing the flow of oxygenated blood through the body so it can provide the organs with oxygen and blood. But unfortunately, if the oxygen and blood are cut off for too long, the ECPR won't be able to have a benefit because really it's just re-establishing blood and oxygen. And if the organs are already dead, then it won't be of benefit. So the people who benefit from this therapy the most are people who have witnessed cardiac arrest and have early high-quality CPR that's managed to keep the blood flowing until the ECMO machine is able to be initiated. Being younger and relatively healthy, having good vessels already to have the blood flow with the CPR will also help someone to survive this massive insult of cardiac arrest and be able to regain consciousness and function after being placed on ECPR. So how do we actually go about initiating ECPR? And Joe's often referred to this as being like a pit crew where everyone has to be ready to go, highly efficient, and know exactly what we're doing. So many steps are required to go from a patient who has a cardiac arrest, for example, at UBC or in the North Shore or even in East Van, to getting them to hospital, to being put on ECMO with a time frame that's compatible with survival, which is somewhere in the neighborhood of 60 minutes or less. So we know that every minute counts in the goal of achieving a survival with a patient with out-of-hospital cardiac arrest. So we've developed a highly efficient protocol that I'll take you through. So the first phase is the paramedic attempts to resuscitate the patient where the arrest occurred. And this is what happens already in our cardiac arrest management. The best chances of survival for a patient with cardiac arrest is if we can achieve a pulse very quickly after the arrest. If this does not occur, however, all of the paramedics in our region have been trained with our ECPR criteria and protocol, and they'll evaluate these patients to see if they would potentially benefit from ECPR therapies. So if so, after they've been trying to resuscitate the patient for about 10 minutes, they apply a mechanical CPR device. And this allows high-quality CPR to continue while the patient's being transported to hospital. This has been a key piece of equipment for our program, as most of the time, if you can imagine, a paramedic is trying to give CPR in an ambulance that's racing through the streets. It's very hard to give adequate compressions, and it's also quite dangerous for the paramedics who are standing in the ambulance while it's going very quickly and giving CPR, and there's been a lot of injuries in the past for that. So this mechanical CPR device has been key in allowing us to provide good quality CPR to these patients. So during the time where it's decided that the patient would be a good candidate, they call St. Paul's Hospital, and we initiate our ECPR protocol, which also calls the cardiac surgeon and the perfusionist, and they come in to help with the ECPR initiation. So over the last 8 months or so, we've been doing regular simulation training, which is key to improve the quality of your team-based skills in order to implement this treatment in an effective and efficient manner, which minimizes delays to the most possible. Here you can see one such simulation in which the emergency department team has just learned that an ECPR patient is en route for therapy. The team is gathered, and you can see they're assigning roles of who's going to do what. This is one of the things that has helped us in organizing. It's all the roles and responsibilities of the team for the ECPR initiation. The writing's too small to actually see what's on there, but I thought it was a good way to show how organized we've been in order for the team to prepare so we can carry out these tasks extremely quickly as soon as the patient arrived and everybody is prepared and organized. Here we've got this down to a science where we know exactly where everyone's going to stand and what they're going to do, where everything is going to go, so everything goes as smoothly as possible. So here you can see in this simulation, the patient is just about to arrive. Everyone's in their prescribed spots. The patient is supposed to arrive within 30 minutes of the cardiac arrest to be on our time schedule. All team members in place, and the physician, as you see there, is gowned and ready to initiate vascular access, which is placing 2 small tubes into the patient's vessels, which will later be used to hook up to the heart and lung machine, the ECMO machine. Here you can see the simulation continues, and here's the physician here inserting these small bore tubes into the patient's vessels, which will be used to hook to the ECMO machine. And we hope to have these small tubes in within 45 minutes of the rest in order to meet our time frame goals. You can see here that the heart-lung machine's on the left side, and you can see one right here in front of you, so you can see what it looks like better. So the next step is usually when the cardiovascular surgeon arrives and the small tubes have been inserted, and then the cardiovascular surgeon replaces the small tubes with larger tubes, which are able to carry enough blood flow from the ECMO machine to the patient to sustain oxygenated blood flow to the whole body. And our goal is to have the time from the cardiac arrest, wherever it may be in Vancouver, to on this pump within 60 minutes. So once a patient's on ECMO, they're treated at our cardiovascular surgery intensive care unit, where they receive expert treatment for ECMO management, and we hope the patient makes a full recovery. So just briefly, I'm going to talk a little bit about our research program that we've developed for this. We're keeping track of all of the patients within the entire metropolitan Vancouver area, and we also have a cardiac arrest surveillance system where we keep track of all the cardiac arrests in the other areas as well. And so we've developed this ECMO program in Vancouver here that we're going to run, and we're keeping track of all our outcomes, and hopefully we'll be able to spread this protocol to other centers in BC once we've got more experience and we're able to teach the other centers exactly what we're doing, so we can spread this therapy more widely to more patients in BC. So thanks so much for listening, and I was just going to ask Dr. Finkler up here that we can just briefly demonstrate how this protocol works here. So I mentioned earlier that the paramedics will bring in the patient, and they now, thanks to our program and some sponsorship that we've received, we have a Lucas chest compression device in all of the ambulance cars who will be identifying the patients. And then, so this is the Lucas chest compression device that we'll just show you here. I'm going to start that up, Joe. So this allows high quality chest compressions to be done en route, and also when we're implanting. If you can hear me over that. While we're implanting the patient, they'll come in with this device on. The paramedics will tell us the story. We'll already have talked to them. And then we'll go about, as I mentioned in the simulations, obtaining vascular access. So these are the tubes that we eventually have to implant into the patient. They're pretty long and extensive. So the physician first identifies where the vessels are that we need to go into, and then we stick a guide wire in, which is just a small wire into the vessel. And this is all while the chest compression device is going on, but I won't turn that on again. And then we have different dilators that we use, not to get too graphic here, but these are entered into the vessels in order to make enough room for these larger ones. And it's somewhere around here that the one cannula gets inserted, and then the other cannula gets inserted here.
Just to be clear, when Dr. Grunau was talking about the vessels, we're looking for the major artery in the vein in the groin, the femoral artery and femoral vein, so we can take the blood out of one and bring it back through the other. Put this external heart-lung machine that works as an external pump for the patient.
And then so this is the heart-lung machine that we had in the picture. This here is the oxygenator, and this is the pump. And basically it's just similar to plumbing, where you have a pump and an oxygenator, and the blood flows out of the vein from the patient into the machine here. The pump pushes it along, and the oxygenator puts oxygen into it. And then it returns oxygenated blood to the patient, and this goes in this one, and then it circulates the body again. So it just it's just a form of external heart and lung, quite simple actually, that keeps the patient oxygenated and keeps the organs alive. And that gives us time to find out what caused the cardiac arrest, reverse whatever happened, such that the patient's able to make a recovery.
Yeah, quite simple, but it costs $150,000.
Obviously, we're paying Dr. Grunau a bit much because I don't know what your plumbing system is like, but I don't have an oxygenator at home. But I think moving on, it's an honor to introduce our next speaker, our next two speakers. But I think Dr. Finkler, it would be fair to say, is a bit of a legend at St. Paul's Hospital. As Natalina told you, I'm a writer, but my writing pales compared to Joe's writing on medical charts. They're not medical documentation. Each one of them is a story, a little novel in and of itself. The radiologists claim that they look more forward to reading Joe's requisitions than anything in the world, because rather than just say chest x-ray, shortness of breath, Joe will say this 48-year-old Italian man who came over with his immigrant parents in the 1970s and had an olive plantation at home, and he'll talk about the loves and losses and stuff. And eventually, if you read his chart far enough, you'll get to the part about the shortness of breath. But anyway, he's a very talented writer that way, and he's a talented doctor. And largely, this whole thing was inspired by Joe and his patient you're about to meet. Joe took a flyer that made a real difference before we had an organized protocol, and he's really championed the cause like Brian ever since. So without further ado, I'll turn it over to Dr. Finkler.
Yeah, thank you very much for having me on this. I came about this not from a research perspective, actually just by accident. As Dan said, you know, we're seasoned emergency physicians. We don't know everything. We haven't seen anything. And I think I was cynical in my, reached a cynical point in my career in terms of cardiac resuscitation, because very little had changed in the 55 years since the introduction of closed cardiac massage back in 1960. That's the compressing on the chest, or cardiopulmonary resuscitation, known as CPR. And really, despite hundreds and hundreds of papers that have been written in the interim, very, very little has changed in terms of improving outcome. And so it makes you sort of cynical. And I'd heard about this ECPR elsewhere, but I just thought this was just another a new thing on the block, and probably not going to turn out to be anything. This is just a picture from one of the classic textbooks in medicine showing how you do the CPR. This is a report that came out from the Institute of Medicine in 2015, and really what the report did, it highlighted the sort of dismal state of affairs with respect to cardiac resuscitation. There's always campaigns going on for treating cancer and other diseases like diabetes, and the funding for those programs is phenomenal, whereas for resuscitation research, it's actually quite poor, and that was highlighted in their report. Despite being a very common occurrence, and probably some people who are dying prematurely, the research funding base is just not there to support it. And so that was really a call to arms for people to sort of get focused on the topic here. You've heard all these statistics before. These come from the American Heart Association in the United States, and that and tell you the survival rate, and it varies. On average, people are saying out of hospital cardiac arrest for all comers, their survival to discharge from hospital is only around 9.5% in the States, and in Canada, that figure is low, but that's the average across Canada. There's quite a bit of regional variation, as there is in the States. I suppose in the United States, the best place to have a cardiac arrest is in King County, Washington, or near Seattle, because people know bystander CPR, and it's a very organized pre-hospital or emergency medical system. I would say probably in Vancouver, we have among the highest rates of survival in the country, probably because of our good pre-hospital care and better CPR. But I just want to tell you about what really was a game changer for me and got me all interested in this as a story. And this is a story about a young man who back in February of 2014 was out on his apartment balcony, slept there overnight, became hypothermic, and came into the emergency department and suffered a cardiac arrest on survival. So we were quite lucky at that time because it was 7 a.m. It happened. We had an A team of nurses coming on for the day shift. I had a very clever colleague coming on behind me who knew about this new compressor device that we had on loan from us from Physio Control. And so we just went about our thing. And then I had this idea. We put the patient on the automated compressor, and this gave us some time while CPR was going on, and we did our normal resuscitation procedures, putting the tubes in line in place, putting a tube in his airway, getting intravenous lines in so we could give medication, and start warming up with blankets. And the idea was, and I'd heard about this, was to start extracorporeal membrane oxygenation. And as you've seen, this is simply, well, it's more than simple, but it's an expensive pump, warmer and gas exchange. It takes over for the heart and lungs, and it warms the blood. And it's very efficient. It's used in the operating room for bypass surgery so that they can do operations on your heart, and your heart does not have to beat and pump blood to the organs. The only difference with this machine is it's portable, and it can be used for a longer period of time, for hours and days. So it's quite an advance there. And it's indicated for patients who have cardiac arrest for hypothermia. So what did we do? We called in the perfusionist on call who agreed to come in, and we called in the cardiovascular surgeon, and he got the vascular access in the large femoral vein and artery in the groin regions, and we connected the patient up to the machine. This is just a circuit. This is just a diagram that's actually happening in our cardiac intensive care unit just a few weeks ago. And this is what was happening to our patient here in the emergency department. And so they're now putting those large bore cannula or tubes in the groins, and they're hooking them up to the machine. And I didn't know if this was going to work. This was like a Hail Mary. This is like when there's seconds left on the clock, there's no downs left, or one down left, and you've got one play to make. And so this was our play, and this is what we did. And so we put the patient on bypass, we warmed him up, and within a couple of hours, his heart started beating again, and he had spontaneous circulation. He went to the cardiac intensive care unit, and then to the general intensive care unit, and walked out of hospital alive less than 10 days later. So I got sort of interested in this. There was a whole bunch of emerging literature. This is a paper going way back to 2003 saying that prolonged cardiac resuscitation using this ECMO device could improve survival. And then came this study from Australia called the CHEER study, looking at out-of-hospital cardiac arrest patients and using ECMO machine, and they changed the out-of-hospital survival rate, which we've seen between 5 and 9% to close to 50%. So for me, I thought, wow, this might be a game changer. Now the numbers are small, and this is not done frequently around the world, so we don't have a lot of information. And then there's some blogs sort of coming up on the medical sort of internet, should we be doing this, yes or no? And I don't think we know the answer, but our hunch is it may work, and we want to study this, and we want to study this in a very sophisticated way. And I think we're well positioned. This hospital has a great reputation for cardiac care, for cardiac cardiac education, and for cardiac research. And so I think we're super well positioned. We're well supported by our department head, who have spearheaded. We're well supported by administration, and we have a checkered flag, not to actually create a program so much as a pilot project, because it's not funded. This is out of the backpack and out of our pockets and out of our spare time, and yet we're able to do this. And it is really quite amazing. We're learning a lot. We've taken courses. My colleague and I have traveled around the world. We started off in San Diego, California, where the only other place in North America where they're doing it, these two guys were teaching us how to do that. So he said, we'll come down and we'll learn from you. We set off to the Alfred Hospital in Melbourne, Australia about a year ago and did the same thing. The other major place that's doing this around the world. And there's a few places in Europe and Japan as well. But really, I think it'll be us and San Diego, California in North America. So it's totally a first. And then there's this organization called the Extracorporeal Life Support Organization, and they're an education sort of program. And I went down to Atlanta, Georgia a couple of years ago and take their course. So people are doing this sporadically. No one's sure exactly if this is going to work. Dr. Grunau has designed a study if we can continue this project to recruit patients and try it and see if it works and make some sort of definitive recommendations. So we're bringing it home. We're bringing it home with simulation. This is exactly what they do in sports. When those people are making a play on the basketball court or in a baseball game or in a football game or it's a military strike, these are planned, rehearsed things. And we learned the hard way at the beginning that it's only by rehearsal and rehearsal that we do this. And our docs are awesome. They're coming in on their own time early before shifts in the evening. Brian's planning. People are putting the time in. And Dan's organizing us, and we do this, and we rehearse so we can squeeze that time down. They say we play like we fight like we train, and that's the way we're going to do it here. So I want to introduce to you our first patient who survived this, Jenya Kaplan, and we've sort of become friends over the last couple of years. I call on my patient every once in a while, bring him out for a beer and make sure he's still alive, because we've got a lot invested in him. I'm going to let Jenya tell you his story. So thank you so much for coming out, and thanks for listening to our story.
Thank you, Dr. Finkler. My name is Jenya Kaplan, and as Dr. Finkler said, I guess I was the first patient who started it all. You know, when I come up here and I listen to all of this, and you know, the first thing, of course, I want to say how grateful I am, and thank you so much for taking the chance and doing this. But you know, most importantly, it makes
saving his life, but not for buying him a beer. No, I'm just kidding.
I bought you most of the beers. But you know what I'm really thinking about is how lucky it really is for me, because you know, like in the movies you see you know, they do chest compression on a patient, and usually they come back to life and everything is great. And I didn't know that I had a 10% chance of surviving this. And really, for me, when I woke up, I had no idea how close I came to being up on that screen, and it could have been my photograph there, you know, as a guy who had a whole life ahead of him to live, and he died, and there was nothing that could have been done. So for me, I know that a program like this is very important because it can save lives. And you know, I know in the academic world there needs to be proof, there needs to be studies, but for me, I know it works because I'm the living proof of it. And I know that you know, my life forever changed on that day, because I now know how easy it is to find yourself in a situation where you know, you think that when you go to the hospital, you know, everything's in place, and there's magically just kind of medicine happens, and you know, everything is in place for you to survive. But it turns out that, you know, there's really not much that can be done for patients that have cardiac arrest outside of the hospital. I had no idea about that. And you know, I feel that people should have that chance, the same chance that I had. I think that you know, programs like that need to happen, and in order for those programs to happen, I guess they need funding, because it is an incredibly complex process. Dr. Finkler and I had many conversations about this, and he described to me like how many things have to fall in place, like how many pieces of the puzzle need to come together precisely in the right sequence, the right timing, in order for this to work. And it's absolutely incredible. And I'm so grateful that these guys are so passionate about it and they're doing this. But I guess at the end of it, they need help, and they need generosity of people like people in this room, in order for this program to continue and flourish, and for more people like me to survive. So thank you very much for coming here, and please support this program.
Thanks, Jenya. It's, you know, incredibly courageous and generous of him to come and share his story and tell what it's like to be on the other side. It's easy for us to fool around with the toys, but to survive that and to come back to talk about it is amazing. And it really inspires us all to pursue this program. Yeah, so I think in a minute we'll just open it up for question and answers to any of us. The cardiac surgeons, like cardiac surgeons, have left the emergency doctors holding the bag up here, but no, they were tied up. It's really been, the other remarkable story about this program that Brian, Joe, and I have been involved in is the degree of interdepartmental cooperation. You'd think that departments in a hospital would all cooperate, but we often work in silos, you know, and pursue our own interests and stuff. And it's amazing the way the cardiac surgeons, the cardiologists, the intensive care doctors, they've all gotten on board. Maybe not right away, but when they saw what was happening, and it's been a terrific story of collaboration that I think makes this program even more special. And while Brian is pioneering a study that really will give the answer of just how good this program is, the places that Joe mentioned in Australia and San Diego already are showing much better results than anywhere else, the ones who have instituted this kind of organized protocol. The program in Melbourne has reported a survival rate of 50% with their, which is staggering improvement in cardiac care survival. So, you know, we're hoping to do the same here and prove it can be done. Great, so I'll open it up now for, why don't you guys just all come up, and Jen, you can come up here, and Brian. And is there any, we'll just, if you put your hands up, yes, go ahead.
For people who live in Richmond, are the ambulances there equipped with this? And also, do they know to rush the patient up to St. Paul's before making another stop on the way?
I'd rather Brian answer that, because I don't think you'll like the answer. Brian?
So really, you need to implement this treatment in a very quick time period in order to have a good chance at survival. So our benchmark is we want people to be on within 60 minutes. And so we've trained all the ambulances in the greater Vancouver area, and we actually just treated a patient from Richmond last week. So it is possible. It's not so much of a geographical limitation that we have, it's more of a time-based limitation. So that paramedics, when they get to the scene, they see how long it'll take to make it to our hospital. And if they think that they can make it by 40 minutes from when they first arrived, then they'll call us and then they'll come. But if things are delaying them and they don't think that, because if they make it by 40 minutes, that'll give us 20 minutes to implement, and that's already super tight time. And people who go on to the ECMO pump after 60 or 70 minutes, you know, in the data that we have, very, very few of them have good outcomes just because it's so long. So we have more of a time-based guideline rather than a geographical guideline of who are potential candidates.
Thanks. And the machine, yeah.
The automatic CPR machine. Are we equipped with that out there?
Not every ambulance.
Yeah, so there's a part of Richmond, there's 4 stations which are in our geographical footprint, and they all have the chest compression device. So there's one, the car that's furthest away is in Steveston, and they don't have the equipment, but the one that's near the border of Richmond and Vancouver, they do. So they do go into Richmond quite a bit, but on the ones on the other side that are more the Surrey, Steveston area, then they wouldn't make it in time, most likely, so they don't have the equipment. Yeah.
Just the only thing I'd add is that the idea of this is to achieve a program, to pioneer a program that eventually can be rolled out to other hospitals. You need a hospital really with cardiac surgery support, so that limits it. But Royal Columbian would qualify, and the idea, is to prove it works, to establish the best protocol here, and then expand to other places. But that could take years.
Does VTH have that? Does it we would get to VTH faster than to St. Paul's?
They don't have the protocol in place that we have. They have the components, but the team and the way it's organized here is a unique St. Paul's. We're the only place in Canada that's offering this. It's not just, so, next question.
I fully appreciate the need for support for this program. I'm very impressed with it. I want to be a little more basic and say, is there a role for the layperson in this, in terms of helping to reduce that time frame? If one is there when something happens, what is the role, and are many of us trained to do that role? And how should we train?
Yes, and that's super important. Like, even to have a chance of survival with ECMO, you need to have someone who's had their blood flowing maintained during the intervening time between the cardiac arrest and when paramedics can arrive. And those are the key critical moments of when the organs have potential to die because they're not getting oxygen. So early CPR is the most critical part of this whole cycle, and that's most often implemented by lay people who are trained in CPR, or even people who don't know CPR and they call 911 and the operator tells them what to do over the phone, and that's had huge benefits in terms of survival. Early CPR, early activation of 911, and then if people are getting really fancy, going and finding a defibrillator at your local bank or whatever, and bringing that and putting that on will even increase survival more.
And so that's why places like Seattle, because they have such a good public education program, their improved survival is definitely, most people more CPR.
What I was hoping you would talk about is that I think many of us sometimes have an intention of learning CPR and don't.
Yeah.
And
really a big, huge stumbling block to CPR was the whole mouth-to-mouth piece, which everyone didn't want to perform, and that's been taken out of the protocols. So it's purely just chest pumping, and everybody should take a CPR course, but it really is, it's really basic, and it is the difference maker, that and calling for help. So, hi, yeah.
I was wondering, do you have standard type of equipment in the hospitals? Whatever you use here, the equipment, is this a standard one, or other hospitals have different ones?
Is this standard
Yeah.
machinery, or is it just specific?
No, this is very sophisticated, no. This would not, this equipment would not be at every hospital. This would only be available at hospital to do cardiac surgery, which would be Vancouver General, St. Paul's Hospital, Royal Columbian in the Lower Mainland, and then at Kelowna, and I think that's Victoria,
Yeah.
and that would be it, yeah.
But we're the only hospital in Canada that has this equipment in our emergency department. There's no other hospitals in Canada that offer this for patients who have cardiac arrest outside, who are treated in the emergency.
So, when you teach in Richmond Hospital or other hospitals, so do they have to substitute for what they use, or how does that work?
Yes, as I mentioned in the presentation, the treatment paradigm for out-of-hospital arrests are the paramedics arrive at the scene, and they, like we mentioned before, they have amazing outcomes compared to other regions, but overall still poor outcomes. But typically the paramedics will go to scene and they'll institute all of the advanced life support, CPR, defibrillation on the scene of the arrest, and if they aren't able to revive the patient, then the patient's typically declared dead on the scene. Because we don't, typically or historically we haven't really had any other therapies to offer the patient in hospital, and there's detrimental CPR quality when bringing them to hospital. So typically all the, put all the chips in the pre-hospital resuscitation. But now the reason that we've changed the paradigm here is now we do have something to offer people that can improve survival substantially.
Yeah, go ahead, sorry, and then we'll go to, maybe next. No, sorry, go ahead, we'll just, go ahead.
I'm listening to this.
Okay, go ahead, ask your questions.
I want to know what part the anesthesiologist plays in this. You never mentioned that.
They're not really involved in this particular protocol. It's the physicians involved are the emergency doctor and the cardiac surgeon. The intensive care doctors come down, but they're largely there for support and aftercare. The procedural part is handled by the emergency physicians, and as soon as the cardiac surgeons can come to take over. It really is just the technical, and the perfusionists are the people who are the specialists who run in the OR. All their job is to run the heart-lung machine. So they were the real experts. It's up to the emerg doc and usually the cardiac surgeons to get the lines, the big tubes in place, that the circuit is going, the pump is going. And for example, last week, Dr. Grunau, the cardiac surgeon, couldn't make it in time. So Dr. Grunau is the one who put in the big lines, and Dr. Finkler's done that before, but that takes some specialized training. But the anesthetists aren't involved per se in our protocol. Do you have a question?
Just wondering what time frames of the study are. Start, stop, how it works.
Yeah, so we'll enroll patients for 2 years over that time period and track all our outcomes and see how well people survive and how many people survive. So hopefully that will be enough to show just a discrete difference.
And just a follow-up question to that, I would assume a lot of these people, even though they get a good start with this procedure, they would still have to have open heart surgery?
Depending on what the problem is. If it's a blocked artery, yes, and we had someone that went for emergency bypass surgery right from the emergency department a few months ago.
In my case, I was back to work exactly months and a half after that happened. Good as new. Nothing.
We thought 6 weeks was a bit long to take off, but that's again, yeah. Question.
You mentioned that you've been given support by both the cardiac department here and presumably administration. And I wondered if the barrier to having this protocol installed in every cardiac hospital in Canada was just a function of money, or is it also a function of the bureaucratic process?
For sure.
Well, how long do we have, Natalie?
It's like money is a huge thing, and for example, with the ECMO machines, they're about 150 grand. So we have some ECMO machines in our hospital from our cardiac surgery. So for the cases that we do, we basically borrow one of these machines, and then, but if we treat one patient, then it's out of commission, and then we're sort of without a machine until that patient's done. And that's sort of why we're looking to get another machine, so we can at least be able to have one available if we're treating another patient. So it's not cheap equipment, that's true. But the major thing that inhibits more proliferation of this kind of protocol is the coordination between different departments and the willingness for people to invest and be enthusiastic about something like this. So for our cardiac surgeons and our emergency physicians, we've basically said we want to do this and we're going to put our time into it. So when there's an activation, we have an emergency physician at home who also comes in, and the cardiac surgeon comes in, and these aren't roles that we get paid for. It's just something that we're excited about, and we want to help establish this as the right thing to do. So you have to take, and the hospital has to take a leap where we went to them and we said, we think this is a good thing to do and we can plan it on our own time, and we're not going to charge you anything for it. And so they said, okay, and they gave us a leap of faith.
Well, not quite a way. They didn't say okay immediately. They said,
Yeah.
It was not a quick okay.
As I mentioned, it took 2.5 years for us to get approval, even when the hospital said, we're not giving you any money, you guys can try and patch it together. So people said, okay, we'll sort of create our new call schedule, and we're excited about this, and everyone got on board.
Yeah,
And knowing what you know now, going from a 5% survival to a 50%, it's a tenfold increase. Even if you say it's 10% to 50, it's still staggering. If you were starting the process today, knowing what you know now, would there still be this 2.5-year resistance, or would it be, this is a no-brainer, we have to find a way of doing it?
That's only, I don't want to get stuck on the 50%. That's one center after a very small number reporting that. And a lot of people don't believe that statistic. And that's one of the big reasons we're doing the study here, to find out exactly what it is. So it's not like there's an abundance of evidence. As Joe said, this is an emerging science. So we believe it to be the case, but it's not been proven yet. So, and it also takes other resources, like there's a perfusionist that has to be on call 24/7 and be within 20 minutes of the hospital. The cardiac surgery group has to be able to respond. It's a very resource-intensive program. So, yeah.
And I think that's why other people would. That's why probably a lot of people wouldn't dare try this. It's a lot of work. I mean, it's like putting people on, all the animals on Noah's Ark. I'm sure they were growling at each other for a little bit, right? And so you got to get the critters to be friendly with each other and to have some sort of trust. And I think that's what now. And Dan shepherded that. You know, that's the leadership thing. It just took a lot of time, but people said, no, it can't be done. It'll never work. It's expensive. Why would you do this? Where's the evidence? And on and on and on. But they've said that about every breakthrough in science, in terms, including going to the moon. So, I mean, sometimes you've got to take a leap of faith and go.
I think, yeah, go ahead.
So the research end of things, or the treatment end of things? Yeah. So, well, treating one patient with ECMO costs about $40,000. It's not super. Treating a patient in the ICU of any hospital is pretty expensive too. So it's not super different. When you compare it to the alternative treatment where a patient's declared dead, that's not expensive at all. So treating, it's true. And when you talk to people who have the budget, it's a large change in the budget compared to the alternative. So it is pretty expensive. But when you see the results, it's compelling. Compared to a lot of the other things that we spend money on as well. The research end of things, we've gotten grants from different agencies. We have about $50,000 to run the research protocol, which will still be tight because we're collecting from throughout the whole province of BC, looking at all the cardiac arrests. But those are sort of some basic estimates.
I saw some more questions. Yes.
When does the age of the patient become a factor in the use of the program?
Good point.
Right up front.
Yeah, so usually there's a lot of data in cardiac arrest research showing that, as people get towards 70, then the likelihood of survival from a cardiac arrest gets quite a bit lower. So with our protocol, it's around there that we call someone a ECPR candidate or not. There's different characteristics of people that might make someone a better candidate than another, and especially the cardiac arrest characteristics, whether it was a witness cardiac arrest, whether good CPR is going on. But that seems to be a point approximately where people don't do well even if they are treated.
So our age cutoff is 65. It was an arbitrary one, and it came out of discussions with our team, our cardiologists, our cardiovascular surgeons. In the study done in Australia, they took them as high as 70, and when Brian and I were visiting there and having dinner with one of the cardiologists, he got phone calls about patients that are even older and sicker. So people will use their judgment, but we wanted to be extremely conservative on the pilot project to ensure we'd have the best outcome.
Yes.
Okay, I just have to, it's not just the material and, you need people like yourself. I mean, you can't be running all the time to be in line for the team.
No. But you can buy a Brian for about 12 grand, 14 top.
Or rent,
It's a fair point, and it's not me. I've been along for the ride on stuff. All these guys really have put so much time and effort. As Joe said, they've traveled all around the world. I went to a meeting in Burnaby once, for about as far as I've gone for this, but these guys have gone to Australia and San Diego. It's taken incredible dedication on their part. They truly are incredibly passionate, and it's a contagious kind of passion that they have for this, and it's true. That is truly priceless.
But you're right, you can't have a program that's based on certain people. It needs to be spread around so that the system is resilient to someone being on holidays or whatever. You can't rely on that. And so that's why we have, a first cardiac surgeon who's on call, and then a backup cardiac surgeon who's on call, and all of our emergency staff. We do simulations regularly where we go through the whole thing, where the patient comes in by the ambulance, the patient's actually a mannequin, and then we do everything. And every one of our emergency physicians goes through this training so that everyone has the skills, and then we continue to refresh that training.
Yeah.
What concerns me is before you get to this stage with all this wonderful equipment, you're by yourself and you feel you're having a heart attack. How do you handle that situation? And you're alone.
Well, yeah. I think everybody just to be 100% clear, because people all the time confuse the term heart attack with cardiac arrest. Heart attack is when a coronary artery is blocked, usually by a clot, and part of the heart muscle begins to die, and people have pain and sweating. Sometimes they get dizzy, lightheaded, nauseous, whatever. But most times, the vast majority, their heart does not stop. The survival from heart attack is very high, 90+%. And it's much more common. Cardiac arrest is when somebody's heart goes straight into a standstill. And usually there's not much warning, and when that does happen, you're not calling anybody because you're technically dead as soon as it happens. It's just that the brain takes 4 to 6 minutes to die. And if you can support the brain by passively circulating blood, and then repair the damage or reverse the damage to the heart, you can keep somebody alive. So if you're having chest pain or any doubt, call 911. It's a whole different situation.
Because women have different
symptoms, don't they? Very true. Women can have very what we call atypical symptoms of a heart attack. But this is a slightly different entity we're talking about today here. Any other questions? Yes? Go ahead.
I'm wondering how many patients you've actually had so far in the study.
Yeah, so we've been gone live since January 1st with our hospital-based protocol, and we're treating approximately 1 a month with the therapy.
I'm sorry.
Approximately 1 a month.
Oh, 1 a month.
Yeah.
And we were doing it before on an ad hoc basis after our first patient, Genya, there, we were trying it, but we had not had the simulation and the organization was not there, and that was evident, we were stuttering and the practice just wasn't there. But yeah.
It was just asking Brian, and that's sort of the target. We thought 1 to 2 a month would be it. 2 of our last 3 patients have actually survived, which is, obviously a tiny number. You can't, but it's promising. I mean, as having Genya here, it's all promising.
Hi, so with early intervention being sort of the key, and you mentioned that PCPs and ACPs have been trained, is there any thoughts about expanding it to FRs and first responders in terms of early intervention?
Well, they still have a role, the first responder, and that's getting on the scene. Firefighters can get on the scene faster because there are more fire departments than there are ambulance stations and paramedic cars around the city or the lower mainland, and they're excellent at CPR. I mean, next to a firefighter, the Lucas is the best thing for CPR. Yeah, they are the best people at CPR because they do more of it and they teach more of it than anywhere else in the province. So their role is actually to get the scene, give high quality CPR, and then when the paramedics arrive and take a history and determine whether the patient's an appropriate candidate.
But at this point, they're not equipped with this machine.
No, I don't believe that any fire department in Canada does. In the States, they do. Yeah, and some of them are integrated systems.
But in our system, it's only the ACP paramedics, the advanced life care, who actually would transport a patient in cardiac arrest. And yeah.
I just have one very practical question, perhaps on your part, is you're looking for support, and how do we, as people sitting in here, direct that support?
Well, at the risk of sounding gauche, certainly we're looking for financial support for this. We desperately want to get at least one more ECPR machine that we're not sharing with the operating room that's ours. We want to get money to support the study. But, you know, to your point earlier about support, everybody who has a chance should take a CPR, a BLS life support course. Should.
I meant financial support. How do we're sitting here and we blow the door.
Oh, Natalina, you should answer. Oh, I'm sorry.
You have your donation form, you have a homicide scene with the donation form inside. You can check off the emergency department and the donations go directly to the department.
Okay, so it's handled in that where we could direct?
Yes,
Okay,
you can direct your funds directly to Dr. Kalla and his team.
but if it goes to the emergency department, does that necessarily go to this program?
Yes, Dr. Kalla will choose where it's directed once it's in his department funds.
I promise you, but thank you. That's a great question. Mrs. Kaplan has a question.
Would you like to come down? She's a very important woman.
Yeah.
She's Jenny's mother.
Stole my life.
Would you like to put
I believe you can hear me, yes?
yes, the video mic on.
Well, now I feel very important woman. But it is really important for me to have a chance to stand here amongst these wonderful pioneers. And I would like to remind you about the person who, many, many centuries ago, decided to use a will, which I personally consider being the greatest achievement of the progress of human mind. And then somebody else decided to use the same will to generate electricity. That idea with electric bulb made him alive. When I saw what was a result of what happened to him, there was no machine in this hospital that he was not hooked up to after that. But all machines will be useless if it were not for that green one in the hands of a clever mind, which was Dr. Finkler. When I came to see him, he told me it was a miracle that we had people who were willing to work as a group. Yes, it was an idea. So what I did exactly what you were asking. After all of it, to support the program, to allow somebody else's, either son or daughter, or father or mother, to be subjected to implementation of such an idea, I wrote a check. And I believe Dr. Finkler, forgive me, but sometimes later, I got an email from him. Would you mind if we use this specifically dedicated money to go to Australia for the conference? And I was delighted. This is how bad it was. This is how it started. And yes, they did it all on their own. And I do remember how much struggle it was to get through certain particular barriers and certain particular, let me say, back off, guys, who knows what it's gonna be. If we don't do it, who will? And yes, I continue to support this program. And I can only tell you one thing. We're all concerned about Richmond, Surrey, Kelowna, and everybody else. But they will have nowhere to go unless they fly to Australia rather than come to Vancouver, to St. Paul. And there is something sane in these people who do it. So I can only encourage you, dedicated to this particular program, and they respect it, including Foundation, to which I am very grateful for supporting and allowing all of you to see us alive. And hopefully, if we need to, get in such a good hands. Thank you.
Thanks.
And thank you.
Yeah. Rumor has it the wheel wouldn't have been developed without the support of our foundation either, but any other questions? Great. Well, I want to thank you again, all of you, for coming out tonight. I want to thank our distinguished panel and Natalie and the foundation, and for all your support. And we hope to have good news to share in a year or two once the study is really up and going. Thank you.